Hello guys, this is Paul and you are watching Paul Medico. In this video I am going to talk about a very important disease of India, that is the Kala Azar. Now Kala Azar is mainly caused by the Leishmania donovani. Now we have to know about something about the genus Leishmania. This Leishmania is a unicellular protozoa which is mainly classified on the basis of the distribution in a New World and the Old World. Both New World and Old World Leishmania can cause visceral and cutaneous leishmaniasis. Now the Leishmania donovani generally causes in the Old World the visceral leishmaniasis. In India, in the Bihar, the districts of the Bihar are mainly affected by the leishmaniasis. So the persons who mainly come from the Bihar are mainly affected by the Kala Azar or leishmaniasis. The main districts are the some Muzaffarpur or some other districts. Now we have to know about the morphology. It has mainly two forms. One is amastigote, another one is the promastigote. Amastigote is present in human beings and the promastigote is present in the vector, that is the sandfly. When a female sandfly bites a human being, then there is a wound is present. In the proboscis of the sandfly, the promastigote form is present. The female sandfly vomit the promastigote form in that wound to suck the blood, to clear the proboscis, to suck the blood. And in the wound, the promastigote form from the wound goes into the blood, and there it becomes amastigote form and engulfed by the monocyte and other macrophages. After engulfment, this amastigote form continuously divide, increases the size of the phagocytes or the macrophages and destroy them, and the new amastigote forms come out, and these new amastigote forms are engulfed by the other macrophages and other monocytes, and they take these amastigote form to the different reticuloendothelial cells. Different reticuloendothelial organs like liver, spleen, bone marrow and lymph node. So in these four organs there will be increased number of the parasitized phagocytes, that is macrophages. Increased number of parasitized macrophages in the spleen will cause a huge amount of the splenomegaly. The spleen is mainly soft and there will be perisplenic inflammation of the splenic capsule, and the hepatocytes generally are not affected, so the function of the liver is less affected, but the Kupffer cells and the endothelial cells in the liver are mainly affected. The lymph nodes are affected, and in the bone marrow the other cell lines, the other cellular development of the bone marrow are suppressed. So we find splenomegaly, a huge splenomegaly with mild hepatomegaly, lymphadenopathy and bone marrow suppression effects, that is the anemia and thrombocytopenia. The other clinical features in Leishmania donovani are mainly in the skin. We find dark pigmentation on the skin. There is a high fever as there is cytokine release from these macrophages, so those cytokines will cause a high fever. Two main cytokines are mainly released, that is interleukin 6 and transforming growth factor beta, TGF beta I think. Now from this blood, in the blood there is mainly amastigote form. This amastigote form, when the sandfly suck blood from an infected person, that amastigote form goes into the blood, goes into the midgut or in the stomach of the female sandfly. From the stomach, this amastigote form goes is converted into promastigote form, and from promastigote form it goes into the salivary it goes into the proboscis, it goes into and blocks the proboscis of the of the female sandfly. So when it sucks blood of the other person, then it will cause another infection. Now it is the life cycle and the clinical features. Now the point comes, that is, what is the lab diagnosis? There are two types of lab diagnosis. Sorry, I missed one thing, that is the post Kala-Azar dermal leishmaniasis. It has three features. One is erythema, one is erythematous lesion, depigmentation, and this erythema and depigmentation is or hyperpigmentation is mainly present on the face and the chest, and there is nodular lesions, but these are generally not ulcerative lesions. If we give these nodular lesions for the biopsy or from the biopsy material, if it is if an animal pathogenicity test is done, then this post Kala-Azar dermal leishmaniasis can be diagnosed, and it is mainly this post Kala-Azar dermal leishmaniasis can be treated by using what is that is liposomal amphotericin B. That is liposomal amphotericin B. I forgot the dose, and another drug, that is SSG. The full form I could not remember. Now comes the lab diagnosis. In the lab diagnosis, there are two methods. One is direct method, one is direct method, another one is the indirect method. In the direct method, we find two things. Sorry, we find three processes. One is microscopy, which is the gold standard method. We take different type of aspirate from the bone marrow, liver, spleen, and from the blood, and we done the slide and see under the microscope if what is that, if the amastigote form, yes, if the amastigote form can be demonstrated in the microscopy, it is the gold standard state and it will be taken as positive. Now generally splenic aspirate is the best, but as there is a high chance of the as due to thrombocytopenia there is high chance of bleeding, so this is not done. Generally the bone marrow aspirate is done from the sternal and from the iliac crest. And the second direct test is culture, and the third one is the animal pathogenicity. In the culture, we at first the material is inoculated in condensing water, and then it is incubated at 24 degrees centigrade for 1 to 4 weeks in the NNN media. And another method is animal pathogenicity testing. In animal pathogenicity testing, we mainly inoculate in the intradermally or intraperitoneally of a Chinese golden hamster, and we generally try to find the erythematous lesions at the site of the inoculation. Then comes the indirect test. In the indirect test, we mainly do serum, that is a serological test. In the serological test, we have to find the antigen. It is mainly done by the ELISA, and we have to find the antibody. It is there are defined method, but the antigen finding is not so much easy, and not so sensitive or not so useful. So we mainly find the antibody by the K39 strain, which is mainly Leishmania infantis. We get this antigen from the Leishmania infantis, or complement fixation test by WKK antibody, or we use but this WKK antibody is also specific for the tuberculosis and leprosy, so we can use another specific antibody for the Leishmania, right? Then comes the molecular method, and there we use the PCR and DNA probe and the Western blot. Then comes the non-specific serum test. In that there are defined non-specific serum test we use. And finally, we use the hypersensitivity test, that is the delayed type of the high hypersensitivity, by pricking the antigen by inoculating the antigen intradermally or cutaneous, just in the frontal aspect of the forearm, and if there is a erythematous reaction, then the test will be positive. And these are the tests, direct and indirect tests. Those are followed in case of for the diagnosis, and for the treatment we mainly use the SSG and the amphotericin B, but this amphotericin B may cause fever, so we replace it with the liposomal amphotericin B.